Good morning. Thank you very much for the invitation to speak. I have no disclosures. So I'm just going to focus here on the final talk in mechanical assist devices, and I'd like to remind you that there are some experts sitting in the room, particularly in the chair, so please feel free to ask them any questions that you wish. And the first thing I'd say is, why in this session are we talking about mechanical support? You've heard how lacking the evidence is in cardiogenic shock. But I think it's important to know these are data from the ELSO registry to see that the use of mechanical support is increasing, and in particular in adults. And I think in part we can relate that to the H1N1 swine flu pandemic from 2009, 10 and 11, which really reinterested the intensive care physicians in the use of extracorporeal support, particularly ECMO in adults. And from these data, you can see, this is a respiratory ECMO, you can see particularly cardiac extracorporeal support in adults has been increasing over recent years. And reflecting that and reflecting the explosion of interest in cardiogenic shock and mechanical devices, the 2016 acute heart failure guidelines did mention mechanical support, and their recommendations had changed somewhat compared with previous guidelines. They certainly recommended that you should consider using these devices in patients with refractory cardiogenic shock. They suggested that you should use the VA SAVE score to help predict which patients may do better or may do worse. And they also commented that you may use extracorporeal support as a bridge to decision when you may actually then decide that your patient is not going to survive and have to withdraw extracorporeal support at a later date. So those are our recommendations in our current guidelines. So in the next 15 minutes or so, I'm going to clarify the indications and goals as they exist today. I'm going to take you briefly through the devices that are currently available and provide some of the evidence. But as requested, I provide you three cases that presented to my hospital from other hospitals in the UK over the previous few years. So the patient on the left-hand side is a lady who was referred, who was 36 weeks pregnant. She's 26 years old, and she is in cardiogenic shock, and she was referred to us to manage her acutely. The patient in the middle was a patient, and Alex Mabaza will recognize a very bad right heart here with severe TR, a patient who suffered significant disruption to the right coronary artery after third-time redo aortic valve and root surgery, and the patient, they were unable to separate from cardiopulmonary bypass. And the patient on the right, which isn't running unfortunately, shows an ejection fraction of about 12% in a lady who presented to a hospital in Wales on the 1st of August this year in profound cardiogenic shock. And the only thing that they found with her was that she had a blood culture that was positive for a Staphylococcus hemolyticus, which is usually a benign organism. And she had profound thrombocytopenic and neutropenic septic shock. So those are the three cases, and I'll come back to them having been through the types of support that are available and how we should use them. The aims of mechanical circulatory support seem relatively simple. Firstly, to resuscitate the patient and maintain end organ perfusion. Second, the most important thing, it is not a treatment, it is a stabilizing measure, and if there's anything that's reversible, it should be addressed immediately and acutely, as being stated by all three of the speakers that have come before me. Extracorporeal support is not a treatment. And in a certain small subgroup of patients, you may find that they benefit in terms of reducing infarct size, but the data from that is small, and it is mostly related to animal studies. Which patients should get mechanical circulatory support is challenging. This is from an editorial written by Bob Bartlett, who was one of the pioneers of ECMO, and also Luciano Gattinoni, who's an Italian pioneer of ECMO. And these were their recommendations nearly 10 years ago, and these are patients that they would recommend considering. So patients with a predicted mortality of around 80%, cardiogenic shock requiring 2 or more inotropes. I have to say that's most of the patients who are on my intensive care unit at the Brompton Hospital. They suggested that the condition of the patient should be acute, severe, life-threatening, not responsive to conventional treatment, which we've heard about from Alessandro Sionis. And again, they reiterated back in 2010 that it should be potentially reversible pathology. I think we have moved on from that to regarding either potentially reversible pathology in terms of cardiac pathology. It has to be potential reversible pathology in terms of all the organ systems of the patient. So there is no point putting a patient with multi-organ failure who is dying on extracorporeal support. They will still die, just possibly later. And additionally, we should not regard transplantation or not as the gatekeeper to whether the patient might be salvageable or not. That is a decision that can be made later if the patient does not recover from the acute insult. The next question is, when should we be doing it? And if you look through the literature, there is a plethora of patients that suggest Intermax 1 or Intermax 1 or 2, definitely before the patient has multi-organ failure, and a number of studies that suggest that there are echocardiographic parameters that could suggest that your patient might require mechanical circulatory support. But again, we have moved on from this. This is, again, from 2010, an editorial that was published, or an article that was published in Current Opinion in Cardiology, suggesting door-to-VAD time and expedient management strategy in cardiogenic shock. And until very recently, people would have regarded that as really an overreaction to the severity of cardiogenic shock. If you look at the guidelines from 2016 in acute heart failure and cardiogenic shock, the concept of time to treatment and managing these patients extremely early, and certainly much earlier than we previously thought, has been introduced. And with our experience in the UK using extracorporeal support for both cardiac and respiratory pathology, referring the patient early is something you will never regret doing. So then on to which type of support. So if we look through the past decades, there are a number of types of cardiac support that are available to us. Some have fallen by the wayside, others are emerging as new technologies. But for all of them, in the acute setting, what we want is something that's safe, simple, easy to do, gives a high degree of mechanical support that can be tailored according to the patient's requirements, and protects the heart, in particular if you wish that this heart, or hope that this heart, will recover. In the context of acute disease, we've moved away now from using implanted devices, not just because of the expense, but also because of the extremely poor outcomes if you put an implanted mechanical device into a patient who is Intermax 1 or possibly Intermax 2. These patients do extremely badly, so we now have to turn our attention to other types of mechanical circulatory support, including the balloon pump, the Impella, the Tandem heart, the Protect Duo, and what I'm going to focus most of my talk on, VA or veno-arterial ECMO. I'm not going to dwell particularly on the IABP because we have been urged from the evidence that's been produced from a high-quality study that in patients with acute myocardial infarction, we should not be routinely implanting the IABP, although its use is still widespread across Europe and across the world. And these are our current recommendations. So this talk is not going to be about the use of, or not of, the IABP. I'm going to focus rather on the Tandem heart, the Impella, and ECMO. So for those of you who are not used to or familiar with the Tandem heart is a low-speed centrifugal pump. It requires a transeptal puncture. You take blood from the left atrium and you deliver it back into the descending aorta. It provides superior hemodynamic support when compared with the intra-aortic balloon pump. The amount of support you get depends on the size of Impella that you put in. And you'll see from the bottom left of this slide that you need quite large arterial and venous sheaths in order to implement this mechanical circulatory support. So that is the Tandem heart. By contrast, the Impella is an arterial system that goes retrogradely across the aortic valve. It's a microaxial rotatory device. It's an Archimedes screw-like rotor, and there are different sizes of Impella, 2.5 and 5. A 5 should be really inserted by a surgeon. And more recently, the Impella RP, which is a pre-shaped femoral device which goes into the pulmonary artery in order to support the right heart. There are emerging data regarding feasibility of using Impella in high-risk PCI. And if you look at, this is a meta-analysis of 100 patients with cardiogenic shock comparing Impella and Tandem heart with IABP. Although there is superior hemodynamic support for these patients, there is an increased adverse event risk, and overall there was no benefit shown, albeit in a small number of patients from 3 different trials, no overall survival benefit demonstrated. So that's the left side of the heart. On the right side of the heart, this is the Impella RP, so you'll remember this is the pre-formed, pre-shaped femoral insertion, right-sided mechanical circulatory support. Small studies, this is just one of them, taking 2 cohorts of patients. Cohort A, patients who'd had a previous implanted left ventricular assist, where they gave temporary right-sided support, and cohort B, patients who'd had cardiomyopathy or a right-sided ventricular infarct, and both those groups received support with an Impella RP. These are the data from this trial. They showed that there was an improvement in cardiac index, venous pressure that was sustained well after, in terms of 20 to 30 days, plus after explantation of the Impella that was only in for a short period of time. And they compared primary endpoints with those that would have been expected from the cohorts that were looked at. So this was not a randomized trial. And from the trial, the authors concluded that it was safe and it was feasible and it was achievable. And they went on, I think, slightly to overstate that it was definitely going to benefit patients in these groups. I think we don't know that yet, both for the left and the right side percutaneous ventricular assist devices. And that's absolutely in line with the statement in the 2016 guidelines that basically says we don't have enough data yet to say that this is the right thing to do for these patients. So I'm going to focus now on ECMO, extracorporeal membrane oxygenation. For those of you in the audience who are not familiar with it, you take blood from the SVC-RA junction, you put it through an oxygenator and a pump, and you deliver it back into the descending aorta. It's relatively easy to do. It's cheap compared with other implanted devices. It's fairly robust if you wish to transport your patient around, and it gives superior support in terms of amounts of liters per minute being able to be delivered to your patient. You need to be mindful of the leg in which you insert your ECMO. We now would favour an arterial line on one side and a venous line on the other, unlike this rather old photograph here. And there is a high requirement for perfusion of the leg with a separate cannula, usually taken off the arterial limb of the ECMO circuit. The evidence that we have, unfortunately, for ECMO is not strong. So you think the evidence in cardiogenic shock for inotropes is bad. For mechanical circulatory support in cardiogenic shock, it's probably even worse, or at least as bad. The best data that we have are these 2 cohort studies where they compared with historical cohorts and showed outcomes before and after starting an ECMO program. And you can see in both these studies there's a significant improvement in outcomes after implementation of an ECMO program. But if you look at the dates where the historical cohorts were taken from, you'll notice that there were significant advances in management of these patients in the cath lab between the 2 cohort times. And so I don't think it is fair to ascribe all the benefit, although much as I'd like to. I think we can't give it all to the ECMO itself, and we have to congratulate our colleagues in the cath labs for their excellent work in these times. I'd also urge you to think that not all shock is the same, and alluding to one of the questions early on, there's not only severities of shock, so you have the patient requiring CPR or almost dead in front of you versus the patient who just meets the criteria for cardiogenic shock. Also, the underlying pathology will fundamentally alter how your patient does. And again, it goes back to Alex Mambaza's talk, where you should be using echocardiography and other diagnostic tests to make a diagnosis and treat the underlying pathology. And then depending on the underlying pathology, it will fundamentally influence what the outcome of your patient is likely to be. In cardiac surgery, unfortunately, the mortality using mechanical circulatory support after failure from separation from cardiopulmonary bypass in published data remains poor, although more recent studies that are in press have shown much better outcomes. And it is felt that this is not entirely due to better mechanical support, but possibly due to much earlier referral, rather than waiting until the patient has multi-organ failure and then ringing and asking for mechanical circulatory support. I think of note, though, even though the outcomes aren't great, if the patient survives the initial insult and survives the mechanical circulatory support, going out 1, 2, 3, and 5 years, the outcomes are extremely good. So the initial mortality post-cardiomyotomy is during the admission, the initial admission and the initial support. Cardiac transplantation, use of ECMO and mechanical support has been a game changer. Early rejection, you can save your patient using mechanical circulatory support and withdraw it after 1 to 2 weeks. Pulmonary embolism, I have 2 studies here, one very early, one from Bob Bartlett and his group, showing that potentially using mechanical circulatory support would obviate the need for thrombendarterectomy and thrombectomy. And a later study from Alan Coombs and his group showing that even with ECPR and massive pulmonary embolism, the survival rates were extremely good, with ECPR 47% in pulmonary embolism, putting the patient on mechanical support, heparinizing, and then withdrawing the support when the heart recovered. Myocarditis, the best group there is, so I would urge anybody in the audience, if you have a patient with acute myocarditis and cardiogenic shock, please do refer them for mechanical support where it's available. The outcomes from these patients are extremely favorable, and a large proportion of them will survive with normal ventricular function. So if you're going to refer any patients, please refer myocarditis. And another group, so the last one of the 3 that I showed you of our patients, refractory septic shock. So this is a subgroup analysis of a group of patients given VA ECMO. You'll see the ejection fractions here in septic shock of 16%, a cardiac index of 1.3, so these patients are very sick. But of those that survived, so 10 out of 14 that were put on ECMO in this cohort, they survived with improving ventricular function, and at 1 year follow-up, ventricular function was normal. Since publication of these data, the group have published another group, but again, it's a small number of patients, of only 34, 35 patients, but again, with very good outcomes. And finally, your worst group, the patients who have cardiac arrest. There are other sessions in the Congress on ECPR, so I'm not going to dwell on it, other than to say most of the interest has come from the CHEER study, which was a single-center study from the Alfred Hospital in Australia. And it was a combination of therapies that we used, so it was mechanical chest compressions, hypothermia, early revascularization, and ECMO. And with the patients that survived, they had extremely good neurological outcomes. And as a result of this, in the resuscitation algorithms, you are urged to consider mechanical circulatory support in certain groups of patients. Taking it to its most simplistic level, from the European Heart Journal in 2014, we're supposed to do all of the things that you've heard about in the earlier parts of this session. If the patient has refractory cardiogenic shock not responding to therapy, you should consider early mechanical circulatory support. When you've used your temporary support, which is the focus of this talk, you should then wake your patient up, assess their neurology, and if their neurology is favorable and they may be eligible for a VAD or transplant, then you should refer them onwards. Otherwise, you should consider withdrawing therapy. ECMO is not without risks. The most that we worry about is intracranial hemorrhage. The rates still remain high. And paradoxically, in the worst performing hearts, if you do not manage your ECMO well within an expert center, you can be delivering deoxygenated blood to the coronary arteries without being aware of it, and may paradoxically make cardiac function worse and absolutely ensure that your patient's heart will not recover. So in order to do it, you need to be expert. And I would refer to some of the variables from this very nice systematic review and meta-analysis done by one of the ESC training grant awardees that was published just this month, that looked at things that we can vary and may not be able to vary in terms of outcomes with mechanical circulatory support in acute coronary syndromes. And some of the things that I think are important are that the target mean arterial pressure being lower was associated with a better outcome. And the biggest decider as to whether a patient did well or not apart from being in North America where the patients did extraordinarily well, was the experience of the centre undertaking the ECMO. So if you refer your patient or you're doing ECMO, make sure that you refer to a centre with expertise and make sure that you have a centre that is developing or already has expertise. So very finally, back to our 3 patients. You remember on the left you had the lady who was 36 weeks pregnant, 26 weeks old, cardiogenic shock with refractory VT. In the middle you had the 52-year-old gentleman who had a 3rd-time redo aortic valve replacement, disruption of the right coronary revascularized with the right heart. And on the right you had the lady with the septic shock that was refractory to all management, and by the time she got to our hospital, she had a cardiac arrest on arrival in the cath lab, so it gives you an idea of how sick she was. The first patient, she had 8 days on VA ECMO and then was changed to a ventricular assist device. The 52-year-old man with the right heart failure had a Protect Duo, which is a percutaneous device shaped like a pulmonary artery catheter, put in much like a pulmonary artery catheter, that provides extracorporeal support to the right heart with an option for an oxygenator. And the lady on the right with a septic shock required 5 days on VA ECMO. And these are their echocardiograms on the left-hand side, 2 years follow-up. So recovery of the left ventricular function. For some reason, I'm afraid it's not running. So recovery of the LV. The right heart did not entirely recover, but the patient was discharged home after 3.5 weeks. And the lady with septic shock who presented requiring eCPR in the cath lab, she presented on the 1st of August and she was discharged home the day before yesterday. So my key messages in terms of mechanical circulatory support are these. I think the first is the most important. Just putting somebody on ECMO or on a device is not treatment. You need to treat the underlying cause, otherwise your patient will not do well. Appropriate patient and possibly device selection is pivotal, and early referral is absolutely pivotal for good outcomes. Although the technique itself is really pretty simple, our understanding of it is incomplete. And I think before we get too excited about ECMO, and I am a fan, I think we need to be careful before we use this technique more widespreadly, because it is not yet proven. And from IABP, just because something seems right doesn't mean that it is right, and we should be rather more careful. Thank you very much.
Thank you very much, Susanna, for a fantastic overview of this difficult topic.